First and foremost, big thank you for everyone for showing up this morning. Thank you for everyone who set up the hall. First and foremost, I'd like to thank the creator for bringing me to Kahnawà, quite frankly. I've learned a lot over the past year. It's a wonderful experience. I hope to bring my family here in the spring. So I just want to say thank you to the community for welcoming me. Second thing I have to mention is acknowledge the fact that this evaluation was not a solo effort. It's not just me, it's an entire team. And it wouldn't have been possible without the team and without everyone who contributed to this evaluation. So this truly was for you and by you. And I want to be grateful and thankful for everything that you've contributed to so that it has become the success that it is. So I also have to personally acknowledge certain people, especially Derek and Lisa and Valerie and Kirsten and Garen Hirorox and Vivian, of course, and Raven, our new team member, setting up the hall here. And so I just want to say thank you to all of them, plus everyone again who contributed to the report. There's too many people to say thank you to, but you know who you are. So without further ado, I'd like to just present some of the findings of the evaluation. Of course, the evaluation will showcase, and you'll get the link to the report, I believe, today. It's a pretty long report, about I think 300 pages, give or take, and it shows a lot of work does need to be done. However, it truly is also a celebration of the past 10 years, of all the hard work that's really been done by the community, by all the various stakeholders towards the health and well-being of the community. So yes, of course, work needs to be done. Yes, of course, there's always shortcomings, but also I think it's important to take this day as a celebration of everything that's been done over the past 10 years, and especially during the pandemic, because it was hard on everybody, quite frankly. So it's really, I would like to see today as a celebration with balloons and good food too. Before I do begin, a lot of you have been asking about the newborn. We had a boy that arrived just 3 months ago. He just turned 3 months. And so he was born in the midst of the evaluation write-up. Quite a challenge, but he's a really lovely little guy, and his older sister is very good to him. Very little jealousy thus far, and he's in good health. The mom is in good health, and we're very thankful for that. So I just want to show the little guy, and pretty happy little guy, quite frankly. He just sits there and smiles at the ceiling sometimes, so can't complain. So just to give a little bit of background regarding the CHP before I begin, of course, you're all more or less aware of what the 2012 to 2022 CHP was, but really it's the third plan developed by Onkwata'karitáhtshera, and it's aimed mainly at strategic alignment of the health and social services in the community, and mainly to achieve some key goals, mainly relating to determining and setting health priorities, and to make sure that there's proper resource allocation in relation to those priorities. Of course, promotion and advocacy of the health and social services in the community, planning functions as well as capacity building functions as well. So these are generally the high-level goals that are set. Some 7 priorities were set by the 2012 to 2022 CHP, and they were addictions, cancer, cardiovascular and illness and disease, developmental disabilities, diabetes, mental health, and obesity. And this was really the main focus of the CHP really over the past 10 years, and it really brought alignment of the health and social care sectors on these specific priorities. Of course, in terms of governance of the CHP, there were subcommittees that were established. I believe about 7 CHP subcommittees that were established and operated, and it focused on things related to looking at assessing needs and gaps in services, developing of service inventories to see who's doing what in relation to these health priorities. Of course, there was the development of logic models or evaluation frameworks that were related to these health priorities as well, and as well developing strategies in relation to these 7 health priorities as well. So that was kind of just the background of what the CHP was. And in terms of the purpose of the evaluation, really I wanted to look at, to assess and evaluate the impact of the CHP in relation to the health priorities, of course. So there were some general key questions that I really asked at the outset during the evaluation. First and foremost is, what are the programs, services, and initiatives that are in place across the community that address these priorities? And you can see that the posters here kind of give a little bit of it fans out. You can see all the various programs, services that do address the priorities, and they're going to be outlined and described in the report as well, pretty much at length. The second question, which is really important then, is what is the performance of these programs, services, and initiatives in terms of meeting the individual and population health needs related to these priorities? So just look, how are the services and programs performing in relation to these priorities? And then finally, the key question, which is, what is the impact of the CHP on the aforementioned priorities? So those were the 3 high-level type questions that the evaluation attempted to answer. In terms of the evaluation design methodology, I tried to look at things from a systems perspective, to really look at the performance of the programs and services from a systems lens, to look at it very comprehensively. And you'll see the framework I'll present in the next couple of slides. So we developed a pretty robust conceptual framework for the evaluation that looks at all the various programs and services across the community from a very multidimensional lens and seeing how they perform from various dimensions. In terms of methodology, I really use like a mixed method types approach, depending on the data that's available. So obviously, we conducted like site visits where we met the teams. I worked very closely with especially the team to see what was transpiring in terms of meetings, in terms of various planning activities, and so forth. Obviously, document review, well over 300 to 400 major documents that I kind of reviewed throughout the length of this evaluation. We use some quantitative data as well, mainly looking at data that can be pulled out of whether it's Mile EMR or Penelope, for example, seeing some descriptive stats that are available mainly. The real bulk of the evaluation was qualitative, quite frankly, in this case, focusing mainly on interviews and focus groups. So we conducted quite a number of interviews and focus groups with various stakeholders across the community, and thank you for everyone's participation on those. So that was very, very valuable to give perceptions on the data that I was collecting. And then finally, we also conducted a content validity workshop that really looked at, presentation of initial findings to kind of get feedback to say whether or not, they were more or less on track. And second of all, looking at the recommendations, the draft recommendations that we drafted to see whether or not, they were valid. In terms of the timeline, it was a very tight timeline. The evaluation started more or less in the summer of 2022. Pretty much the official launch date was in June. In July, I came down for a site visit. Throughout July to October, it was a lot of data collection, interviews, and focus groups. By October, it really was now synthesizing the recommendations for the CHP and then working with the stakeholders to really making sure that, I did the data analysis correctly, did some validation sessions as well, and working with the executive steering committee for the evaluation to make sure that things were pretty much on point and valid. So that's kind of the timeline. Again, a pretty tight timeline for the evaluation, more or less 6 months. Some of the limitations that has to be said from the outset is, in terms of quantitative data, it was quite limited. So there was limited, reliable and robust quantitative data that I could pull out of the systems, whether it be Mile or EMR or other type of recording systems. So in terms of quantitative data, it was a bit limited. In terms of course, one has to mention, the ability to interview everybody in the community. It's impossible. I mean, obviously, due to the limitations of the time, I did try to get as much representation as possible, but of course I may have missed certain stakeholders. Of course, that is not intentional if that happened, but so I couldn't interview everybody to get everyone's perceptions, but I tried to get a representative sample from the programs and services, as well as, of course, we all have biases, whether it's the person I'm interviewing or the people in the focus group or myself. We all have certain worldviews, we all have various perceptions, we all have various roles in the system. We all look at things differently. So we have to mention that, of course, bias is potential there. And another issue that also was a limitation was it was hard to assess trends over the 10 years. So there weren't like systematic evaluations conducted like annually to look what's going on every year for the CHP. So it was very hard for me to kind of create like a longitudinal type evaluation. See, here's how we trended, for example, between 2012 and 2022. It really was more or less like a cross-sectional evaluation, looking mainly at the present state and looking back at the midterm evaluation at 2016, seeing where did we go from 2012 to 2016 and then to the present. So at best, I would say that's where it was at. And finally, another limitation is, we didn't formally interview or get any input from the clients or patients directly. We tried to rely on what data the programs and services were collecting from the clients and patients themselves. So if a program or service was collecting client input or did client surveys, then I try to use that data as a secondary kind of like proxy to kind of see like client experiences, for example, or patient experiences. So that was a limitation, mainly due to time. It's not that we don't value patient experiences, because that's at the crux of everything, but it's, again, due to the limitations of the time frame as well, to do a meaningful client input. My apologies about the size of this slide. Again, this is in the report. But as I said, I tried to look at the performance of the programs and services from a comprehensive systems lens, right? So looking at it from multiple dimensions and domains. So I looked at it in terms of, looking at the capacity of the system or the structures, looking at things like, the structural enablers or organizational like structures and resources, things like the funding, the facility, the infrastructure, the IT, human resources, looking at education, training, governance and leadership is really important. And then looking at the various service delivery models that are out there in terms of what are the standards that the models have in place, what are the guidelines that they use, what are the protocols, et cetera. I also looked at the performance of the various programs and services from various performance domains. Looking at things like access, looking at teamwork, looking at functions related to communication, collaboration, and coordination, which are fundamental functions that program services need to do. Looking at functions related to community engagement, because all program services across the community do those functions. Looking at how they ascertain client, caregiver, and family experience where relevant. Looking at how program services do evaluation and quality improvement, looking at what information systems they use and how they use them. Of course, looking at the processes they will put in place and the structures they put in place for the pandemic response. All the program services has certain responses to the pandemic and certain processes. Looking at how they address things related to cultural safety and cultural competency, which is extremely important for every program and service across the board. And then looking at how they integrate culture and language within their program and services as well, where relevant. And then in terms of outcomes, looking at, are there any outcome measures that I could use related to measures of client, caregiver, or family experiences, for example. Looking at, are there any measures out there in terms of the outcomes related to team experiences or provider experiences, including things like burnout. Then that ties into the other domain of employee health, wellness, and well-being. Are there any outcome measures that I can look at related to that? Do we measure that in terms of employee health and well-being and wellness? Are there any outcomes in terms of all the activities we do related to culture and language? Are there any outcomes that we see in terms of further integration of culture and language in the services? Are there any outcome measures related to cultural safety, for example, measures that are taken? Looking at the impact of the pandemic from various dimensions as well on the programs and services, because it had a massive impact on all program services and providers. And then finally, actual impact on health priorities. So looking at, are there outcome measures for diabetes, for mental health, et cetera, that I could look at and put into the report. So I tried to really look at the program services in terms of performance from a very multidimensional lens and from a systems perspective, because ultimately these are all like systems that you can bolster and strengthen. So if I had to sum it up, if I had to sum up the story of the 300-page report, what I would say is this. This is what I really learned here. There is an enormous array of programs and services across the community, health and social services and public sector services that really address, people's needs across the lifespan, all the way from preconception all the way to death. So there's a really large array of program services, and you can see as you walk around today, you see there's an enormous array of services out there for the population in Kahnawà. We also see, I would call it a significant developmental transition, moving away from, being a set of disparate services towards more being like systems, where trying to get the services to start to work together to be more person-oriented, because it's usually the same person who's accessing multiple services, and people are cognizant of that and seeing it. So I'm seeing that transition of saying, okay, we've developed really nice sets of services across the community, but we're trying to move now towards building systems. And I think everyone's on the same page in terms of the importance of integration, coordination, communication, person orientation, and that is really resoundingly clear throughout the evaluation. And we're seeing that transition starting to happen, really, moving away from just this service, that service kind of silos, and the importance of moving towards systems. Another important thing is also developing systems that are, not just Western-centric, but also that start to integrate, actual like indigenous and Kahnawà concepts of health, wellness, and well-being. And I think there's recognition across the board of the importance of that, and there are programs and services across the board that are starting to try to actively do that, and to try to build standards that are meaningful to them, assessment tools that are meaningful to them and to the community. So I'm seeing that transition happening too. So, and then as well, other certain domains that are really being focused on is the importance of not being service-oriented, but like client-oriented. So not being just oriented from the perspective of the provider per se, which is also important, but it's really being oriented around the needs of the individual, the patient, and the family. And so it's all about person orientation, family orientation, understanding that, again, because it's the same person that accesses multiple services, that it's really important to have some sort of coordination, some sort of communication happening. Cultural safety is huge. I mean, people really are starting to recognize the importance of cultural safety, and they're trying to see ways of making sure that that's integrated. Family preservation is a very large theme as well that people are recognizing as a very fundamental determinant of long-term health and well-being. It's all about the family and at that level. The importance of community engagement. I think there's more and more recognition. I mean, everyone's doing community engagement across the board, but there's more and more interest and focus on that domain of saying we really need to get the community engaged, and getting especially sections of society that maybe aren't so engaged or hard to reach. They're recognizing the need to be able to reach out to them and meaningfully engage with the community and get their input into the design and evaluation of services. And then finally, the recognition that we need to start measuring and evaluating how we're doing as services. I think it was across the board that people were saying, we do want to see how we can measure success. We do want to see how we're performing. We do want to evaluate how we're doing things, but to evaluate things that are in a way that are meaningful to us. So again, it's integrating more like Kahnawà, like concepts of performance, for example, and well-being. That's important. And also, how do we improve? Like everyone wants to improve from their present state, and that ties into evaluation, but how do we use the evaluation results to improve? And so, for example, partners all across the board are focusing on quality improvement. KMHC has a whole unit dedicated to quality improvement. So there's a lot of cool things happening across the board, quite frankly. So that's like a very high level, like 30,000 foot level. If I had to say, that's kind of the story that I'm seeing here. So I'll be going through basically all the various major domains of performance that I measured in the framework. That was part of my conceptual framework earlier. So we'll be going through all these domains right now one by one. Again, this is at a very high level. In the report, it'll go into the details and a bit more description, of course. But at this point, I'll be talking for another 20 minutes, give or take. So I'll just give you the very high level kind of findings for each of these domains. They're quite generalizable across the system. They apply to most programs and services, quite frankly. So I try to keep these findings at a high level. The specific findings are available also in the report. In terms of organizational needs, so clearly, the complexity and the needs of the community is increasing in many different ways, whether it be in the scope, in the level of the complexity of the clients that you're dealing with, the psychosocial complexity, for example, and the intensity of services. So that is becoming very clear that the needs are only. We're seeing mental health issues, especially post-pandemic, substance use issues, family issues, complex psychosocial issues happening, and so the complexity is really increasing. So they do, program services across the board are trying to adapt to meet these needs because, things are only getting more difficult, the workload is only more intense, and so that's become an issue. The health portraits, there are 2 volumes of it. The volume 1, which was published, volume 2, I believe, is upcoming and forthcoming to be published soon. It provides really good evidence in terms of the increasing complexity of the population across various health domains. So that's going to be very clear, especially with volume 2 of the health portraits. And I believe the regional health survey will be redone next year, hopefully, as well. So you get updated community data on the complexity of needs, which I'm sure will be shown to be increasing in many ways as well. So it's clear, the evidence is there. The complexity is increasing across the board. Now that ties into the fact that a lot of the models of care haven't kept up with the complexity, or aren't able to keep up with the complexity. A lot of times the models are somewhat antiquated, the physical infrastructure may be antiquated, the space may not be enough, the equipment may not be up to date. There are many different issues. So in terms of organizational needs, a lot of the program services did articulate the fact that, for example, you need more space, or better design space, or better equipment, or various types of needs that the organization needs. So clearly there's a requirement for having a kind of a finger on the pulse of the program services, see what is the needs now, but also in the next year and the next 5 years, so that we're not reactive. So we really are making sure our program services are designed properly, they're equipped properly, outfitted properly, so they don't kind of fall between the cracks, or kind of now fall into kind of like that panic mode all the time, which you really don't want to be in, and be more proactive. In terms of service delivery models, so there is increasing kind of standardization of the models out there in terms of getting more consistent kind of service delivery across the board. So trying to use good standard assessments, trying to leverage some good guidelines, kind of use good protocols. So they're trying to professionalize. They're trying to standardize a lot of program services, trying to make sure that have a certain level of consistent quality every time. So if 4 people access the same service, they get kind of a consistent quality and standard of care. Obviously, there's a lot of work on redesign continuously across the board for various program services, focusing on various performance domains to make sure they're accessible, people can access their services, that they're efficient, they're effective, they're culturally safe. So obviously the models are not static. As time changes and the complexity of the population changes or needs change, the models are trying to adapt, but also trying to maintain some level of consistent quality and standard. However, having said that, as I, kind of looked across the board and I kind of evaluated the various program services out there, there is a bit of variability. Some program services kind of are well standardized. They have, consistent kind of quality metrics and so forth. Others are still trying to figure out how to really establish their models of care, for example. So there is a bit of variability in terms of, the models of care that are out there and the implementation of standards. Even things like, evaluation. Some are, don't have very strong evaluation frameworks, for example, in place. Others really have very strong evaluation frameworks in place. So it really depends on where we're looking at. And again, the evaluation report kind of goes into more detail. Access is enormously important. We all recognize the importance of low barrier access, particularly for more vulnerable, marginalized maybe segments of the population. During the pandemic, obviously, there's been implementation of virtual care and telehealth, which is really great. We've seen that. A nice thing is virtually all the services and programs out there do kind of like measure and monitor participation rates. So they all kind of look at, who's accessing services, when are they accessing it. So those kind of statistics, descriptive statistics do exist. So that's really wonderful. You can build upon that. One has to give a shout out to programs such as home and community care, which do a great job in terms of access. I think, having worked in home and community care across many jurisdictions, the fact that people can access home and community care in the time that they do, it's quite admirable, and it has to be really mentioned here. Having said that, access for more, I'd say marginalized or special needs populations or vulnerable segments of populations is more challenging, and there's recognition of that. Even things like, for example, how do we engage teens, for example, especially during the pandemic and post-pandemic. So there are various segments of the population that, obviously need to be reached and make sure they have low barrier access to the services that they could benefit from. And there's recognition of that. Lack of transportation is one obvious one. That sometimes that really does limit people's abilities to access various services for themselves or their kids, or especially in things like winter. So that has been a significant challenge. Obviously, I mentioned in terms of the models and the organizational needs, if your space is not designed properly, then people who have, for example, certain disabilities may not be able to access it. For example, physical disability, it may be an issue, right? So that may be a particular issue. Sometimes you don't have the right staffing to deal with the complexity of the needs of the clients. Then your service isn't fit for purpose for those particular clients, for example. So that could be an issue too. There is also a challenge, but this is across the board in many jurisdictions, of access to primary care. So, and what I mean by access isn't just like walk-in clinics, but more like, are you attached or registered to a primary care physician? This is a significant challenge. A significant proportion of the population, to my understanding, have challenges accessing primary care and being attached to a primary care team or provider. But there have been initiatives in place to kind of bolster the human resources in primary care in the community. They're ongoing, and so that's a promising thing in terms of access, especially in the weekends and so forth, to fit for long-term care. But they're also too intense for home and community care. Where do they go, right? They're also addressing issues with mental health and making sure that people with mental health issues can be kind of like provide services in the community, for example, to a greater degree, and also more comprehensive focus on mental health issues as well. And then substance use, of course, is a growing issue everywhere. And concurrent disorders, mental health and substance use, of course, is a big issue. And designing services, again, that are within the community that people can leverage and use, rather than being having to access them elsewhere, which sometimes causes some externalities. Teamwork, one of my favorite topics in the world, because without a good team, nothing good gets done. I really believe that, and having a good team is it's the best thing one can have. Everywhere I go in the community, whether it's fire and ambulance, or education, or health and social care, wherever you go, people work as teams. And it's pretty well established in that everywhere I go, people recognize the value and importance of having a team. And they recognize that the development of high-performing teams doesn't come like naturally. It takes effort and resource. Like, teamwork is not something that just put a bunch of people together and say, run with it. It takes a lot of effort to build high-performing teams. And to do that, organizations need to recognize that this takes some resource. It takes some both administrative and technical resource to make sure your teams are performing up to a certain standard, and that they're healthy and they're engaged and they're delivering good services together. Having said that, there have been challenges, especially in situations where you have multidisciplinary and multi-professional teams that they come with different worldviews. So say I'm a certain team member, I'm biomedically oriented, I was trained in that world, I come to the team with that very kind of like biomedical, clinical perspective. At the same team member, team has, say, a more psychosocially oriented person who comes with that worldview. How do we reconcile the biomedical and psychosocial together? Because we're working as a team, right? And that's something that it's ongoing, and it has ways of how to optimize the work between those team members. Also, sometimes team members don't understand the other profession well. They don't understand what is the scope of practice of that other team member. What is their legal parameters of work? What are they able to do, what are they not able to do? So sometimes it's a matter of a team really understanding who the members are, but also their functions and why they do things the way they do. So that has been a bit of a challenge sometimes. Sometimes there are legal designations that forbid a certain provider from doing something, quite frankly. And sometimes team members don't understand that fully. It's really important to, if you want high-performing teams, to be able to continuously kind of monitor and assess how the team is doing. So to have some sort of mechanism, whether it be a huddle, a survey, whatever it may be, but to have some good systems to be able to assess and monitor how's the team doing, how healthy is the team, how are they performing, what are the problems, how do we address them. So it's keeping that team healthy, high-performing, and kind of having a finger on the pulse on how that team is doing. Huge topic, the 3 C's, I would call it. Nice thing is I got a lot of consensus in this evaluation. I didn't get a lot of fighting in terms of some of these domains. Everybody recognizes the value of communication, coordination, collaboration. Nobody came to me and said, no, I don't want to collaborate, I don't want to communicate, I don't want to coordinate. So there's universal consensus more or less of the importance of it. Now, they also recognize that these functions are extremely important when we deal with clients who are more complex. Complex clients, use multiple services across the community. And when you're using multiple services, that's when these 3 functions are essential, right, for delivering safe and effective care for the client and a good experience, too, for the client. So they're not being redundant or negating each other. And examples are, the frail elderly, clearly, people with mental health and or substance use, right, individuals with special needs and their families, people with multimorbidities, with chronic illness and disease, and people with all 4 of the above, right, or 3 of the above. So, the importance of these functions are really critical as we move forward and how to really optimize these. Now, the other thing, although everyone told me, yes, we all want to communicate, collaborate, coordinate, everyone also was saying we work in silos. They're kind of dismayed the fact that we work in silos, we're fragmented, we don't talk to each other. And, but at the same time, being in the position that I was in, and being able to take that 30,000-foot level view, I actually could see, there's a lot of formal and informal mechanisms of coordination happening on the ground. So it would be interesting to do a mapping exercise, see actually who do all the stakeholders in the community work with, how do they cooperate and collaborate, and to strengthen those web of interconnections. So there are these functions happening. They maybe just aren't well recognized sometimes, because everyone I talk to is doing these functions in some way or another. Everyone, from a service provider to a manager. Could they be improved? Absolutely. Examples of good cross-sectoral collaboration is like Wellness Action Team, which was a really good example of that. However, having said that, it's not always the fact that, I'm just an unpleasant person who doesn't want to talk to someone else. It's some more structural as to why sometimes we see barriers to communication, collaboration, coordination. It's not always the fact that I just don't want to talk to anyone. So some of these structural factors are governance, for example, or organizational variables, which is different organizations have different ways of doing things. And it's not amenable for them to work together because they have different processes, different SOPs, different guidelines. Again, it depends. There could also be barriers like professional barriers or disciplinary barriers that we talked about earlier in terms of the worldviews that we have. Information technology. Sometimes EMRs don't talk to each other. So for example, just a clear example is like Mile EMR and Penelope case management don't speak to one another. They don't interoperate. That creates a bit of a barrier to communication, collaboration, coordination sometimes. Other factors are personal factors. Sometimes just people don't want to work together. So again, there are many different ways that there are barriers to this, and we just need to identify and address them and put plans in place to address these various barriers, because they are totally, can be addressed. This is a really interesting topic in terms of the functions of community engagement. The nice thing is that virtually everyone I talk to across the community is doing community engagement one way or another, right? So wherever you go, whether it's the peacekeepers, whether it's the hospital, whether it's social services, education, they recognize and do community engagement so that the community has input into the service design and delivery as well. Having said that, if you talk to 10 different people about what community engagement means, you get 10 different answers. So there's no kind of consistent idea of what we mean by community engagement. Sometimes it's defined differently, sometimes it's done differently. And there's nothing wrong with that. It's just a matter of sometimes recognizing that we're engaging the same people. So sometimes it's good to have more alignment in terms of how we do things and why we're engaging them. So we're not just kind of battering people with different engagement strategies. It's also more efficient for programs and services sometimes to work together and have a good strategy saying, we're engaging the same folks, let's just work together, right? So that may be a really good way to move forward in terms of community engagement. Another thing is, it's easy sometimes to engage the mainstream, so to speak. It's hard to engage some certain individuals and subpopulations in the community, right? And we need to be mindful that community engagement should not be a checkbox exercise, that we just, okay, we did it, we can move on with our project. We had a barbecue and we're done. Really, how do we meaningfully engage the community, get their feedback on an ongoing basis, and also the more unheard voices in the community, like who are they and how do we reach them better in a meaningful and respectful way as well. So and I know everyone's kind of trying to address that. People recognize the value of engaging, especially those individuals in the community. And as I said, people should just think about working together, because often they're engaging the same exact people, and might as well work together on that sometimes to be efficient. This is a really, really big one. Getting the experiences of the users of the system, right? People are using, that's the key. I mean, as providers, we see things in a certain way. Like, if I'm a director or manager of a service, I may think that I'm doing a great job because I'm working really hard, right? And so do my team members. Might not look like that from this perspective of the user sometimes, and they usually have really good input and feedback to give us. I always view feedback from the clients and the users as a gift, good or bad. They're taking the time to tell us how we're doing. And that ultimately benefits us to provide a better service for them. And the happier they are, the happier we are. And I think that ultimately is the story. So everyone agrees it's important to get the user's feedback and the client's feedback and the patient's feedback regarding the services. However, there's an enormous amount of variability across the system in terms of whether it's done, how it's done, and how that data is used. So that's an issue. Having said that, it's also not so simple sometimes to get meaningful feedback for clients and patients. Sometimes, it could be an ethical issue with regard to getting their feedback, privacy issues. It could be also technical. Like sometimes when you're dealing with really complex clients, who is usually the population you really want to hear from, it's not as easy as just sending out a survey to them, because there could be like cognitive challenges. It could be like various challenges with just being traumatized and not being wanted to talk to in a certain way with services. So it is not so easy to just engage clients, not just like, a quick survey that you can send out sometimes. It takes some energy and resource, but it's well worth the effort usually. So as I mentioned, it's important to do it. To do it properly, definitely there needs to be some dedicated supports, both administrative and technical, like what type of tools or approaches do you want to do to get the feedback from the clients and users. So it's really important to put those supports in place to make sure that we're not just getting client experiences once, kind of like cross-section, but it's continuous, that it's ongoing, that we're always getting feedback continuously and measuring trends over time and seeing how we're performing. So this is just a super important domain. My favorite one, because that's what I do, looking at the program and services in terms of evaluation. How do you evaluate yourselves? How do you evaluate your performance? How do you evaluate your quality? How do you improve your quality and your performance? So the nice thing is, there's been an amount of effort over the past 10 years, especially through a CHP, to do things like develop logic models around the priorities. The CHPI, Community Health Plan Initiative, requires the development of logic models and so forth. So people are kind of socialized to the idea of what a logic model is. Having said that, my sense is people are not very, they don't really like the word logic model, or they don't like the way it's been done to a degree, and that's fine. However, having said that, there have been good examples of really a good focus on evaluation quality improvement. For example, I know KMHC has the QURMI team, the Quality Innovation and Risk Management team, which is doing some pretty phenomenal work, not just in relation to QA and accreditation, but also looking at the next step, which is quality improvement and learning health systems as well. So pretty impressive. Having said that, if you talk to all the various program services across the community, there's a lot of variability in terms of the evaluation capabilities or what's been done to date in terms of evaluation. So there's a lot of, again, variability in terms of that. The development and use of logic models, I think, has been somewhat challenging over the past 10 years. I think that process can be simplified. I mean, ultimately, a logic model is just a tool for self-reflection and evaluation. I think if it's used or looked at in that way, it can be simplified and made to be useful. What I've seen just from reviewing existing logic models, again, I'm generalizing here, but what they look like is more like detailed work plans rather than a strategic evaluation framework. So for me, a logic model for program service generally is like 3 to 4 pages sometimes, max. Sometimes I saw logic models going into like 40, 50 pages. So like there's a big difference between like a work plan, which is very detailed and that's not really an evaluation frame, versus a strategic framework for reflection on what are we doing, what are we trying to achieve, how are we doing it, what are the enablers to help us do that. That's really the questions what feed into the logic model. So that's a big difference in terms of approach. It's also important to learn from one another in the community. As I mentioned, there are certain programs and services that really do a great job in terms of evaluation frames, quality improvement frameworks, and there's opportunities to cross-learn within the community in terms of how to do things. So I think more communication between the partners and collaboration could really bolster and align how we do evaluation and quality improvement in the community. One of my favorites too, data infrastructure. An enormous amount of effort and resource has been put into place, implementation and change management into implementing data systems, notably MILE EMR at KMHC and Penelope case management system at KSCS, done during the pandemic, which is never easy for change management. So clearly a lot of effort has been put into place to do that. We all recognize the value of that because in the future we're moving towards data-driven systems in the next 10 years, clearly, with technology. Organizations have put resources and supports in place to help people on the front line especially use those systems. However, there are challenges with, obviously, they've been implemented during the pandemic. It's always difficult to get change management to be done. Even without a pandemic, it's hard to implement EMRs anywhere. It's not easy. So there's a learning curve that's always tough. And organization cultural change. It's not just a technical exercise to make sure the EMR is adapted and the proper fields are in and the proper forms are integrated. There's a lot of cultural and organizational cultural change that needs to happen. But also things like, we need to address things like interoperability. You know, again, it's the same client accessing KMHC, same client accessing KSCS, but the systems, when they don't interoperate, sometimes there's some redundancy or sometimes the data is in different systems. So there's opportunity to look at how do we build more data flow between the systems, and that's being addressed in many other jurisdictions as well. It's the same problem everywhere, that EMRs don't speak to one another. Again, something that can be resolved through proper planning and can be addressed. The next step, so we talked about the data sources in the EMRs, is now you put the data in, now how do we use the data? So from data to information to make decisions, right? So obviously, you know, all the organizations everywhere are collecting masses of data. You know, anyone who's providing services is collecting data, recording the data, and storing data. So the data is there. We have a lot of data. It's now moving from data to information, which is really important. And so everyone recognizes the importance of that we're not just coding, you know, information into our records, but that we're actually using the data to reflect on who's using our service, we can design our services properly, we can evaluate, and so forth. Having said that, in terms of using data for looking at the health profile of the community, the Health Portraits Report, Volume 1 and Volume 2 that's forthcoming, provides a good snapshot of population health statistics because it collects data from multiple sources. So that's really great. But in order for us to use data to move towards information, it's really important to start that process of moving towards, you know, first and foremost, developing business intelligence functions. So having business analysts integrated into organizations to be able to collect the data, create nice dashboards, create nice monthly reports, seeing just basic descriptive stats, starting from there, and then moving and progressing more rapidly into data integration and health informatics. So again, that's recognized, and I think we will, you know, the community will embark upon that journey in the next short future, hopefully. I integrated this domain, although it wasn't formally integrated in the original CHP because there was no pandemic when it first was published, but I thought it's essential to really look at the impact and the response of the pandemic. It's really clear that, you know, whoever I talked to, you know, people went above and beyond everywhere. Clearly, you know, high levels of resilience, the fact that people continued in their jobs and provided essential services is incredible. A lot of empathy, a lot of selflessness, a lot of really sacrifice that I saw, that people would really go above and beyond to make sure that people got the services they need in the community, which is amazing. And again, this just demonstrated an enormously high level of intrinsic motivation to your staff. A lot of your staff are from the community. They care not just for the community, but about the community. And this is almost like an unspoken resource. The fact that Kahnawà has that high level of intrinsic motivation to your staff is an incredible resource that needs to be treasured and protected, quite frankly. So not all communities are this fortunate. A lot of people come in 9 to 5, check in, check out. We don't really care about the community because it's not ours. It's a very different story here. People really care and have a vested interest in making sure they deliver good service to the community. So that I found was very special, especially the sense of social purpose. I don't see that everywhere I go when I do evaluations. Sometimes it's a day job for people. This was quite special. I think it's something we really need to recognize and build upon, quite frankly. It's a special resource Kahnawà has. Organizations did provide a lot of supports for their staff. They tried their best in many ways to make sure that they focus on their health and well-being. Also to make sure that, you know, service delivery was continued Yes, of course, there were shortcomings, but again, the pandemic was very strong. Organizations, I think, were scrambling sometimes to figure out how to deal with things. But overall, you could see the response from even an organizational level in terms of trying to protect their staff also as well. However, having said that, along with resilience, burnout is widespread. We're all burned out. We're all traumatized by this. And that was very, very clear that, we're in a healing phase. With the pandemic, even though, people say, oh, it's over, but no, like people are kind of dealing with the trauma they've dealt with. People are truly, they have PTSD and they're burned out. And it's clear when I talk to some of the people on the front line, the managers, across the board. It doesn't matter who you are in the system. If you're a CEO, if you're a manager, if you're a frontline, everyone's borne the brunt of this pandemic. A major issue was change management. As you know, during the pandemic, things were moving at a very fast pace. Protocols were changing, safety protocols. We have to do this, we have to do that. It was very, very high levels of change and high levels of uncertainty, which are the two magic recipes for burnout. So that was a major issue. There was challenges in maintaining essential services in the face of the pandemic. Many essential functions, especially performance appraisals, had to be postponed. There were examples. The Wellness Action Team will come out with a report soon, I believe, where they surveyed over 400 community members. They compiled a very big inventory of services that address the pandemic. So that will come out soon, I believe. And as well, it's important to mention that the community was a model for many other communities like other indigenous communities looked to Kahnawà for their response to the pandemic, because they did actually mobilize in a very special way, and you saw community-wide mobilization happening and a lot of solidarity. So it served more or less as a model to a degree. This is a very, very important domain that I really tried to give focus on. There are actually 2 recommendations in the report relating to this. And it's clearly recognized across the community of the value and the importance of culture and language, even as a healing force for the community. So that's really, really well established. As I went across the community, talked to various program services, they all have culture and language integrated some way in their strategic planning, for example. So they do recognize it. They've tried to implement it in their planning processes. Having said that, it would be great if, again, program services can start to work together to kind of have more alignment in the way they kind of focus on culture and language. The Wellness Action Team was a good example of good collaboration, of integration of tradition and culture and language in their programs and activities. So that was really good. The pandemic was enormously disruptive to culture and language activities, which is not good because, again, culture and language is a mediator for health and wellness, and it's a protective factor even during the pandemic. So making sure that if a future problem happens, like a new pandemic, God forbid, or whatever may happen, that these services continue and they're not disrupted by these emergencies. They almost should be considered essential services, quite frankly. And again, cultural safety and competency frameworks are very important. They need to be integrated in the various program services to make sure that there's a certain level, a certain standard there in relation to these domains. So the final bit, in terms of the community health plan, in terms of the question, what is the impact of the community health plan on the health priorities? Statistically, quantitatively, I can't give you that number. Like I can't give you like the percentage of, for example, for diabetes or something. That quantitatively doesn't exist for me to be able to quantitatively say statistically that we've had this direct impact on this priority. That's almost impossible to answer using the data that exists, quite frankly. Hopefully that will change in that as we use the EMRs better, as we use quantitative data better, I can also be able to answer that question in a future evaluation, for example, more accurately and statistically. However, having said that, it's very clear that there is an enormous array of program services that address the health priorities. I mean, that's very clear. Just walking around here, you'll see that. Conceptually, there's been agreement across the board that we need to move away from just focusing on specific conditions and diseases towards being focused more on wellness and well-being and health outcomes, more outcomes-oriented. And also being able to integrate more holistic understandings of health, wellness, and well-being from more like a spiritual and emotional lens that integrate more indigenous and Kahnawà concepts of health and well-being that are not just biomedical or Western-centric. Again, there was limited, integration of performance frameworks in the original CHP, so it was very hard for me to be able to measure and assess statistically, the impact on various health priorities, because again, there wasn't that indicator framework established in the CHP initial report. There were also challenges because as I talked to program and services, sometimes people say, well, I don't really know what the CHP is. So that's a knowledge transfer and exchange thing in terms of people being socialized and understanding what the CHP is and how it relates to their program and service. So some people weren't really aware of what it is. And in terms of the CHP subcommittees, there was quite a bit of variability in terms of their performance. Some were performing quite well, others were kind of still informative stages. So it really depended on what subcommittee we're looking at here. For the future, So building upon this, moving for the future. We want to move from a community health plan to more a community wellness plan. What does that mean? It really focuses on moving away from just diseases towards more like person-oriented outcomes, focusing on the wellness and well-being and the health of individuals. Again, integrating more holistic understandings and really focusing on integrating some certain principles, concepts, and orientations, I would call them. The principle is that the CWP, the Community Wellness Plan, is not something that I just draft with 4 people and then give to the community and say, here's your Community Wellness Plan. This is a co-construction. This is something that needs to be built by and for the community through meaningful engagement. We need everyone's input on this. This is, again, not just something a team would do on the side and then say, okay, here's the report, everyone run with it. That's not how it should work. Self-determination in that we want to move away from, Western biomedical concepts, but also integrating proper, indigenous and Kahnawà concepts of health and wellness, which is really important. Transparency, that there are good indicator frameworks in the report that you can measure success very clearly and transparently. So that when you say, oh, I'm doing great, we can measure it and showcase it properly. Accountability, that all the partners have shared accountability for health outcomes. They all say this is how we're contributing to it, and they're accountable for it. Teamwork and collaboration is an obvious one. Data-driven, again, it ties into using data properly to make sure we're evidence-informed in the way we're making our decisions. Concepts, again, talking about integrating proper indigenous concepts and frameworks. Social determinants of health need to be integrated properly in the next community wellness plan to make sure we address social determinants of health because they're fundamental. Cultural safety is an important concept that needs to be at the center of things. Onkwata'karitáhtshera is very important, culture and language, essential. And as well, as I mentioned, concept of knowledge transfer and exchange. So people are always aware of what the community wellness plan is. People are all on the same page. We all kind of understand what we're talking about, which is very important. And again, orientations being outcomes oriented, focusing more on upstream prevention, early intervention is very important. Oriented around the users or the persons rather than just the services, and then focus on the family. It's very, very critical. So these are just all general themes that need to be addressed in the next plan. So yeah, that kind of reiterates what I said in the previous slide. In terms of what are the future priorities for this community wellness plan, the previous 7 priorities in the community health plan are valid. We all understand diabetes isn't going away, mental health isn't going away. However, they want to expand upon that. So what they want to expand upon that is really looking at other domains as well that are very important, that reflect the health and well-being of the community. Domains related to culture, language, and identity. Again, looking at outcomes related to family wellness and well-being and healing. So how do we measure that? How do we measure that families are protected and are thriving and healthy? Looking at violence as an important domain, which is very complex, and we need to tease that apart because that's a very multidimensional domain, and it's a very important one because, again, they mentioned this back in 2016 of integrating it into the old CHP. I think now definitely must be looked at in terms of integration. Expanding mental health and well-being to look at not just specific diseases, but also broad cross-cutting mental health conditions as well. Primary care is very, very important to focus on as well for next CWP to make sure people have access to comprehensive team-based primary care that addresses their needs, right? Social determinants of health goes without saying. Teen and youth health and well-being is really important. Especially in the pandemic, the teens were really hit hard by the pandemic, and with social media and all that, we all recognize the importance of making sure our teens are healthy and that they thrive as young adults. Injuries is one that will come in the second health portrait report. Harm reduction, so integrating that into substance use kind of like priorities, making sure that it's not just a punitive approach to substance use, but also more balanced, looking at harm reduction and domains. Aging is a huge one, the aging population, also including aging caregivers. How do we address that? How do we address healthy aging at home? People who fall from between the gaps between home and community and long-term care. All these types of things are really important. Even being innovative, things like elder adoption, right? So like things like that. Developmental disability, special needs, huge. The pandemic brought to light the importance of looking at staff health and well-being as a domain that's really important. Again, healthy provider, healthy patient. So that's an important thing to look at. Climate change is an important one to look at because that's just real. It's happening. It's affecting our health directly through water quality, through air quality, all these types of things. And the final domain, which is actually really important to look at, is just happiness, which is now being recognized internationally as something we just kind of take for granted. But how happy is your community? How do we measure the happiness of the community? And I think that's something that's really, really important to look at. And that was mentioned during the interviews, which is great. The recommendations are all in the report. I won't go through all the details, but generally the recommendations, if you read through them in the pamphlets that you have, look at things from a systems perspective. All the recommendations talk about building systems. So it's building systems related to developing your organizations to make sure they're well resourced and well outfitted. Developing systems for making sure that you have proper human resources in place for the future. Making sure you have staff and continuity of staff and also local staff and youth who can be hired here. Service deliveries, make sure you have systems to make sure your service delivery models are consistent in terms of standards, in terms of quality and performance. Systems to bolster teamwork. Making sure you have high-performing teams functioning, multidisciplinary and multi-professional teams. Systems for communication, collaboration, and coordination. Again, a good system for community engagement, right? Rather than just a one-shot at communication by service. It's more like we have an aligned strategy and system to engage with the community. And the same goes further and further. Systems for evaluation, strategies for data. Like now we have all that data, how do we transfer it to information? You need a clear strategy for that and a clear system to do that. What do we put in place for staff well-being? What do we do in relation to culture and language in terms of making sure we have proper strategies to make sure that we meaningfully integrate culture and language in our programming and service delivery? And then finally, we talked about community wellness plan. So basically looking at strengthening what exists in terms of strengthening the models of care on the ground, but now broadening their scope to integrate Kahnawà concepts of health and well-being, to integrate culture and language, to integrate broader social determinants of health, to look at the family. So really it's strengthening what exists, but now broadening their scope and making sure they talk together through their systems, right? So that's really what that's all about. And so that's really a pretty lengthy presentation, but it gives you kind of an overview of the system level performance that I found. You can walk around, see all the various program services, and I'm always available for questions. You'll get the link to the report. Hopefully I made some sense, and thank you.